So welcome again. Thank you for spending a bit of your lunchtime with me, or lunchtime here in North America, in Toronto. I'm not good at multitasking, so I'm going to now not look at any more Q&A and chats because it's just too confusing for me. I want to do one thing at one time. So my name is Dr. David Kunashko. I'm a chiropractor, acupuncturist. Back in the day, I've been practicing for about 30 years, graduated from CMCC in Toronto. Before that, I was in molecular biology and molecular genetics at University of Toronto. Before I decided that I didn't want to be a lab person. So I moved on from graduate work into become a chiropractor. And I've been involved with laser therapy or low-level laser therapy, but the actual technical term, the term I prefer is photobiomodulation. However, I still use laser therapy a lot because basically that's what everyone knows it as. So that's you're gonna hear me say that a lot. But the research term photobiomodulation or PBMT is what you're going to see a lot in the research as well. My goal today is to go over a knee osteoarthritis. I'm going to do a summary review for you from a really recent paper from the Lancet. It was really good. I just happened to come across it. I learn a lot every time I do these webinars because it allows me to do some research on the most current research evidence. So I can pass it along to you so you don't have to kind of read this stuff, and I have access to it. So I like doing that. I learn a lot. You guys hopefully learn a bit as well too. Then I'll talk a bit about some of the evidence-based treatment that's out there. I couldn't put everything in, but I put a lot of stuff in there because it's really good to know, because you need to have your patients have options, right? That's part of your goal, is to give your patient options on how to treat and how to deal with the osteoarthritis. And then, of course, we're going to get into photobiomodulation or laser therapy. That's the name of the game, right? And some of the research, there's tons of research on osteoarthritis and knee and laser therapy. I've just selected a few. And then, of course, how we approach treating osteoarthritic knees here with our BioFlex equipment, and of course, Q&A. So the paper I'm referring to was published in January of this year, so it's super recent, and it's from the Lancet. So it was a review of knee osteoarthritis. So most of this information is coming directly from that paper. We all know knee osteoarthritis is really common. The current stats are about 37% of people, so that's over the age of 60, have knee osteoarthritis. This was from a survey that was published in the United States, National Health and Nutrition Examination Survey. Of course, it's more common in women than men. I say of course because in general, women's joints tend to degrade sooner than men because of the decrease, the size and just genetics and sexual differences in the structure as well. So that's the deal. And the prevalence, of course, is just going to go up and up and up because the population is living longer, and you're going to see more of this. So laser therapy is really effective for knee osteoarthritis. It's one of those things where if you were to advertise and market just this alone, you should build a busy practice just doing osteoarthritic knees. Of course, osteoarthritis represents a failed repair of joint damage from usually stresses of the joint or the tissues around the joint, the periarticular tissues like the synovial lining and so forth. We all know that cartilage loss is the main thing that we talk about, but it's not just cartilage loss, right? So we need to treat the entire knee structure, including the muscles that surround it, because they sometimes atrophy and become problematic. Sclerosing of the bone. Cartilage breakdown, of course, is common. Ligament dysfunction, maybe you don't realize, but the collateral ligaments and structural ligaments are affected by the inflammation as well. Synovial hypertrophy, so the synovial lining hypertrophies, and you get a lot of exudate, inflammatory exudate going into the synovial fluid, causing unfortunately, a cycle of inflammation. Osteophytes, we're all familiar with that as well. So these are all things that are going around the knee joint, not just the hyaline cartilage. And of course, the meniscus can also be affected as well. Symptoms, we all know the symptoms. I'm going to go through this fairly quickly. Pain, stiffness, reduced joint motion, some swelling, a muscle weakness. These are all common things. So these are all things you need to treat, not just the inflammation, right? Long-term consequences, of course, reduced physical activity, that sets up a negative, kind of cycle, and then less exercise, more atrophy. Of course, there's deconditioning. People get out of aerobic shape, impaired sleep, depression, fatigue. These are all things that we're all familiar with, especially during COVID, right? The worse the symptoms, the more that they can be affected, and of course, the more that they show up on imaging as well. So there are factors that are associated with increased risk, including the older you get. That makes sense. I mentioned female greater than male. Of course, overweight. Now, doctors are great with saying, oh, just go and lose 20, 30 pounds, right? And you look at the doctor and they're like 50 pounds overweight. So it's not just about losing weight. I mean, we're talking about on the heavier side. And of course, losing weight's helpful, but it's not the be all and end all. So unless the person's significantly overweight, look at the other things as well too, because people just get focused on that they're overweight or whatever, and they don't think about these other things as well. History of knee injuries, occupational factors like repetitive knee bending, heavy lifting, and squatting. If you have genu valgus, genu varus, that also contributes. That's why women tend to be more arthritic as well, because they have more of a genu valgus, right? Genu valgus. The risk is not increased with, believe it or not, the risk is not increased with recreational physical activity. So, if you go out there and play sports, that kind of stuff on a recreational basis, you're not more prone to knee osteoarthritis. You would think you would be, but it's only extremes. Extreme like a professional player or a really serious athlete that you tend to see it more prevalent. So pain from OA of the knee is difficult to study longitudinally because it does go up and down. So it's tough to do that. Of course, we know there's episodic pain. It is generally speaking predictable and becomes less predictable and more distressing as it gets more severe. There's other factors associated with pain, including younger age tend to be more painful, female greater than male. You can see them all here: obesity, burden of a coexisting condition, psychological factors, pre-existing conditions like depression, pain catastrophizing, and pain sensitization. These are all things that people become more aware of their symptoms. So sometimes there's a psychological overlay that you need to deal with as well. Well, I mean, meaning you should refer out, unless you're, of course, you're a professional in psychotherapy or for that type of profession. With the exception of younger age, these factors are also risk factors for functional impairment as well. So these risk factors include, of course, older age, falls, misalignment. I think I covered this already. Greater physical activity, poor social support, and so forth. So if you have good social support, like friends and all that kind of stuff, you actually have reduced risk, which is interesting as well. So symptoms obviously always begin gradually. In the men, they tend to be in the 40s and or older, and in women, it's perimenopause or older as well too. Pain is usually dull initially, involving the entire knee, but it can be more localized, oftentimes in the medial joint line as well. Rest improves it, but as the disease advances, then you might start getting pain, or the patient might start getting pain in the evening as well, or interfering with sleep. So morning stiffness, it can last up to 20, 30 minutes as well. And that stiffness occurs briefly after daytime inactivity too. So one of those cardinal signs are, for example, what's it called? The movie sign. The movie sign is essentially you're sitting down watching a movie. Well, back in the old days, right, when we could go to movie theaters, but now on the sofa, and then you get up after 20, 30, 40 minutes or an hour, and your knees are stiff. That's an indicative sign of some arthritis in your knee joint as well. So findings include crepitus, that was the clicking or creaking in the joint. Pain and bony enlargement, that's due to sclerosis or osteophytes, reduced knee flexion contracture, and tenderness as well. Erythema, which is redness, a bit of warmth and swelling, but it's usually pretty mild. If you see a lot of redness in a joint, a lot of warmth, then you had better get that knee checked out for something like an infection or sepsis, or maybe a gout or some type of more serious condition, because that's not typical for generalized osteoarthritis. Remember, there are no blood or urine tests to diagnose osteoarthritis. So if you look at x-rays of a normal knee joint on the left, you can see there's nice healthy spacing in between the femoral condyles and the tibial plateau. On the right, you can see this is maybe moderate osteoarthritis. You can see that the spacing on the medial joint line is decreased. You can see sclerosing of the tibial plateau, and you can see little osteophytes, both on the femoral condyle area, and you can actually see beginning of the ones on the tip of the tibial condyle as well. One of the most common scales used for x-rays for osteoarthritis of the knee is the Kellgren-Lawrence or KL scale. You can see here from a 0, which is a normal healthy knee joint, and then you can see the grading of 1, 2, 3, and 4. 4 is basically bone on bone. 3 is moderate to severe, and 1 to 2 is mild to moderate, right? So that's, and I will mention this a little bit later on, this KG, or KL scale, not KG, because it comes up in a research paper as well. What's important to understand here, and this is really fascinating, is that on the left, what you see is normal, healthy hyaline cartilage, right? Chondrocytes are hypoxic cells. They do not want oxygen. They get their nutrition through the synovial fluid. That's critical. As soon as you start to introduce blood flow in and around hyaline cartilage, it actually causes degradation. Contrary to what you would think, it doesn't want blood flow. So what happens is you get what's called vascular channels, which is, you can see here, don't mind my cat, I don't know, my cat's. So I digress. So these vascular channels form because the bone breaks down, and it starts to cause increased vascularity through the sclerosing bone, and starts to penetrate into the actual hyaline cartilage. This allows nasty cytokines, inflammatory cytokines, to actually penetrate and enter the hyaline cartilage and start to break it down. So you don't want increased vascularity to the hyaline cartilage, and unfortunately, that's what happens during the process of degradation due to osteoarthritis. So early OA is characterized by the infiltration of mononuclear cells. They produce these pro-inflammatory cytokines and other mediators that can also accelerate articular damage as well. The synovial inflammation is really important because it can cause both pro and anti-inflammatory mediators to be secreted. Specifically, interleukins 1 and 6, and remember those 1 and 6 because it has a direct correlation to what we can do with laser therapy as well. These are nasty interleukins or cytokines, and they can increase the cascade of degradation, leading to more and more joint injury as well too. So treatment in recent years has actually shifted, hooray, from pharmacological therapy, boo, to non-pharmacological therapy, yay. So that's because, guess what? Pharmacological therapy doesn't work for osteoarthritis. GPs and medical doctors out there, you're way better off doing lots of other things other than medications for osteoarthritis. We all know that. So let's all get on board with that, which you already are because you're listening to this webinar. So remember, treatment of knee osteoarthritis is multimodal. I will mention some drugs for sure. And, that is still commonly used, but, it's kind of a last resort. And to be honest, it's not something I'm going to usually recommend to my patients. Well, I'm a chiropractor, so I'm not going to prescribe drug, but even over-the-counter stuff, not a big fan. So patients need to be educated regarding osteoarthritis. So make sure you have lots of good information for them. They should understand the value of strength training, isometric exercises if they can't do joint motion. Lots of good information out there. Injury prevention, role of coping skills that we talked about earlier, like a social network, those kinds of things. Importance for a proactive approach is really critical to help manage osteoarthritis. Now, let's talk about exercise. I do have quite a bit about exercise because it's so important. This is one of the essential components of the management of knee osteoarthritis. So contrary to what you or people might think, is that exercises don't necessarily pose long-term risk, okay? So systematic review of studies of low-impact exercise in older adults with knee pain or osteoarthritis showed no increase in pain and no progression of the disease on imaging at that group level. This is all from the Lancet paper. I don't have the reference here. It's all in the Lancet paper. If you want to read the paper, let me know. I can. I'm sure I can get that to you. Actually, I got it for free. I just signed up to the Lancet, and they give you 2 free papers. So that was kind of cool. So I can share that without having any legality issues. So exercise goals include maintaining or improving aerobic fitness, range of motion, strength, reducing risk of falls. And other studies have shown the benefits of aerobic exercise like treadmill, running around on the track, community-based walking, strengthening. I mentioned isometrics, but isokinetics, elastic band exercises. Everyone knows all these things. So if you really need to encourage your patients to be proactive with respect to that. Neuromuscular exercises is focusing on reducing weakness and improving sensory motor control, like wobble boards, those kinds of things as well. Aquatic exercises, extremely beneficial for knee osteoarthritis. Balance exercises. In fact, there was a nice randomized single-blinded trial that talked about Tai Chi. And Tai Chi ended up showing that it was just as effective as physical therapy. So for doing it for 12 weeks. So it was a really good study. So Tai Chi is one of those really good forms of social, well, you can do it on your own, but it's also a social kind of activity as well too. So exercise ideally is initiated and personalized by, there's a physical therapist, this is from the States, right? Or physiotherapist, chiropractor, massage therapist, whatever profession you are, you can do this. And you need to consider the patient's preferences. So everyone's going to be treated differently, manage their expectations. If they say, hey, I want to continue running like I've done since I was 20 years old, it may not be a realistic expectation. So as much as the patient doesn't want to hear that, give them options, right? So it's important to do that as well. Remember, multimodal therapy for a lot of these things can be done remotely. Whether it's COVID times or non-COVID times, you can actually help patients doing it remotely as well too. 1 hour per week, moderate to vigorous exercise was associated with a greater likelihood of remaining free of disability than activity lasting less than 1 hour per week. Okay, so that's kind of the benchmark. Of course, we know in patients who are significantly overweight, then we do recommend that weight loss is part of the plan as well, the plan of management. Other things like self-efficacy and self-management programs, education, setting goals, all these different things to manage pain and fear because people don't want to do anything because it hurts or what have you. So you need to manage all that with appropriate behavior modification. Medications, well, I'm going to really run over time today, I know it. So topical medications, there was a meta-analysis, again, this is still from Lancet, a meta-analysis from 7 randomized control trials showed a benefit of treatment with topical NSAIDs similar to oral NSAIDs, but with fewer side effects. So if you're gonna, recommend something, I guess a topical one as opposed to an oral one, right? Clinical practice guidelines and systematic reviews strongly recommend against arthroscopic partial meniscectomy. This is really important because this was standard of care for decades and decades and decades. Oh, let's just go and snip shit out. Oh, so snip things out. I didn't say that word, did I? And now the evidence shows that no, you shouldn't be doing that. So yeah, not a good thing to do. If there's locking or what have you, and meniscus is in the way, yeah. But otherwise, the evidence is not supporting that. Glucocorticoid injections can provide short-term relief. I'm not a big fan because repetitive use of it can also damage the articular surface as well too. It's funny, they say, well, maybe just get it if you have some big event in your life and you need to get through it. I suppose, sure, I don't know, if you're getting married and you want to climb Machu Picchu, get your injection and whatever, but it's temporary, right? So I wouldn't necessarily recommend that, but it's an option. A recent randomized trial showed that physical therapy was similarly effective in the short term and better in the long term than glucocorticoid injections. So regular injections are not recommended, as I mentioned. Again, this is all evidence-based coming from the Lancet, so I tend to believe it. Systematic reviews and meta-analysis of RCTs indicate that acetaminophen might provide some minimal efficacy. However, we all know acetaminophen warrants monitoring hypotoxic effects of your liver. So if you're gobbling up acetaminophen pills every day, long-term, there's long-term downside to that. So let's look at other options, right? Now, what about glucosamine and chondroitin? You know, I've recommended it in the past, but I've only said try it for 2 months. If you think it's helping, continue. But the evidence is still not showing it's really doing much. So I don't know. I'm on the fence on that one. What about PRP or platelet-rich plasma? It's gaining popularity, showing that, in fact, it can be very helpful. I'm not going to go into what it is and all that. You can research it on your own. So the studies are showing there's favorable outcome of reducing symptoms and mobility in these patients, with it being a long-term benefit up to 12 months. So, and there's no serious side effects. You just take your blood, spin it down, get the platelets out. But if you're going to do this, make sure you go to someone that knows what they're doing. There's different forms of PRP, how it's spun down, how it's taken, administered. So I would really look into that quite well. And also laser therapy is shown to increase and have additive effects to PRP as well too. As stem cell therapy as well, or mesenchymal stem cell, which is derived from bone marrow, adipose tissue, or umbilical cord, that's also very popular. And again, so far the systematic reviews are looking promising, but there's still limited high quality evidence. So they still need to do lots of follow-up with that. However, again, personally, I think it's a good option. What about curcumin extract? I take that every day. Actually, just noticed I ran out today. So you know what? The evidence is showing that that in fact, compared to the placebo, there appears to be benefit with respect to OA pain and function. So I would recommend that people take, you need to take enough of it too, right? So it's not just a little bit, you need to take the appropriate dosage as well too. Another interesting thing I came across was vitamin D. It seems to actually improve, so supplements improve, vitamin D supplements improve pain and function in patients with knee osteoarthritis. There is lack of strong evidence, but it's leaning towards that way. So it doesn't hurt to take vitamin D as well too. All right. Now it's laser therapy time. So why photobiomodulation? Well, it can have a role to play in collagen formation and repair, muscle regeneration, help with improving muscle atrophy, reducing inflammation, reducing swelling, helping cartilage repair. Why wouldn't you add photobiomodulation to the mix? Because it does all of these different things. This particular paper was really interesting. They actually measured through the blood metallomatrix proteins, which is indicative of degradation of the joint. They also looked at cytokines. They also looked at the radiological effects. And they looked to see if the hyaline cartilage was improving secondary to laser therapy. So, which is really fascinating. So they did 17 patients in the active group, 17 patients in the placebo group. They did 8 different points, 1.5 joules. They used infrared, by the way. I think it was, I don't know, I think it was 904, 905 super pulse, but it doesn't matter. If it's in near infrared, it's gonna work. 60 seconds per point, 12 joules. Overall, they looked at VAS, the joint space width, collagen production, that matrix metalloproteinase as well. And they looked at it before treatment, post 4 weeks, and post 8 weeks as well too. Here are the points they used in the anterior knee. They did the knee joint line. They did over the femoral condyles, the tibia. I don't know why they did it over, I guess for the synovial membrane, but you can see over the tibial, just distal to the tibial plateau, and then back in the popliteal region as well too. So after 4 and 8 weeks treatments, the active laser group shows more significant difference than the placebo laser group, and overall the results show low-level laser therapy was more efficient in reducing pain and improving cartilage thickness through biochemical changes, right? So that's pretty good evidence to show that if you do consistent care, you can help the cartilage growth. This was a long-term randomized controlled double-blinded study, low-level laser therapy, along with exercise therapy. Again, exercise therapy is critical. The objectives were looking at pain and functioning, and also radiological evidence. They only did 10 laser therapy treatments over 3 weeks, and then they did follow-ups as well to look to see how these patients were responding. I won't go over all the details, but the conclusion was that there was immediate post-intervention improvements, and that laser therapy plus strengthening exercises, the benefit was maintained for 6 months. So ongoing treatment is critical, but even just doing a session is going to last a good length of time. So there's 2 ways of approaching this, and I'll talk about treatment plans towards the end of the webinar today. Okay, this paper was not a human paper, but I wanted to talk a bit about it because it's really interesting to show how laser therapy can affect the joint. So they looked at inflammatory mediators in acute joint inflammation. This was done on the knees of rats, and they injected the knees to get degradation, and they treated it with 4 joules of 808 nanometer of laser, and then they did it either for 80 seconds or 40 seconds, the same dosage of 4 joules. And I'm going to skip right to the crux here, is that longer treatment times with less energy is usually better than more energy and short treatment times. Sorry, class 4 laser folks, but that's what the research and science says. So I don't want to hear your arguments otherwise. So this is what this is what it looks like on the left. A normal, healthy knee joint of a rat. Kind of looks like a human, right? Well, some humans are rats, so there you go. And then on the right, you can see the degradation of the hyaline cartilage. These were 3-dimensional model imaging taken of these joints. So what they found was that there's significant reduction in the inflammatory cells in the synovial fluid from both the power levels. However, there is larger reduction in the macrophages at the 50 milliwatts as opposed to the double that. They also found reductions of the nasty interleukins. Remember I mentioned this earlier, 1 and 6. So the mRNA, which will code for the protein for these interleukins, they were lowered with 50 seconds, but even better, with 50 milliwatts at 80 seconds, and it was better than 100 milliwatts at 40 seconds. So my point is, you're better off doing less energy for longer than increasing the energy a lot and doing it quicker. As clinicians, we're always trying to want to do stuff quickly and efficiently, but when it comes to laser therapy, that is not always a good thing to do. Okay, so how do we approach treating arthritic knees with BioFlex equipment? 2 things you're really trying to address here. One is the articular cartilage, and one is all the surrounding structures, including the synovial lining and the membrane that's producing all this anti-inflammatory nasty stuff, right? Along with all the other surrounding areas like the muscles and the ligaments and so forth. So that's what we're trying to do. Now, one thing is important to understand is that if you want light to go into the joint as optimal as possible, then you want to have the knee in an open pack position. Remember, that's around 25 degrees of flexion. So best to position your patient in that about 25 degrees of flexion. Don't have them with an extended knee, and certainly don't have them in full flexion, because you will minimize the amount of light that penetrates into the joint cavity. In fact, I was reading a paper, I didn't present it here, but one of them makes a point of saying treat in the open pack position. And I was like, that's cool, because that's what you should be doing. And it gives you better results. Okay, now protocol-wise, I'm not going to go a lot into protocols because we have a knee protocol. Dr. Khan spent decades perfecting this knee protocol. It works extremely well. Now, we do customize it a little bit, and what I'm going to recommend is usually arthritis in the knee is medial affected more, so we increase the time from 6 minutes to 8 minutes for red and 6 minutes to 8 minutes for infrared. That's continuous wave in 50-50 or 50 hertz, 50% duty cycle. That's a stage 1, the lower portion of stage 1. It's important that the array is placed so the midline of the array is placed over the midline of the joint line. And then on the lateral placement, similarly, but again, we're going to go now down to the 6 minutes and 6 minutes of red and infrared. And we also treat the popliteal region as well. This diagram isn't very good because it's in the flex position, but you do want to extend that knee out a little bit more into around 25 or 30 degrees of flexion. And you might ask, well, why do a posterior placement? Because this really allows good access to light into the sometimes people have Baker's cyst or into the back of the knee to allow light to penetrate into the posterior aspect of the knee joint as well. So 3 placements typically is what you're going to do. Yes, it's a lot of time, but this is all hands-free. So go about and treat all your other patients at the same time you're doing this. You don't need to be there with your patient during this time frame. Okay, laser probe time, right? So the idea with laser probe is that you're going to have a lot more energy in a smaller surface area, which allows for that light to accumulate to deeper areas. So make sure the knee, again, is in 25, 30 degrees open pack position. On the medial side, you're going to try and follow the knee joint line all the way around the back of the knee as well. Start off with about 10 to 15 seconds per point. And excuse me. At approximately 40 to 50% of power, you can increase the power and increase the time if you're not finding the results there, okay? But start off at around 10 or 15 per point. This is on the joint line, okay? And then on the lateral, similarly, 10 to 15 seconds per point, 40 to 50% power. And okay, so the yellow is the head of the fibula and the arrow is pointing to the tibial plateau, right? And again, you're going to follow the lateral joint line all the way around and to the back of the knee as well. So you're going to go right from the front of the knee, anterior aspect, all the way to the lateral aspect, and then the posterior lateral aspect, and do the exact same on the medial side as well. Anterior knee, we're going to treat around that patellofemoral joint all the way around. I prefer, if this is the case, you can actually kind of move the patella out of the way a little bit and try and get that light directly on the joint line. Again, 10 to 15 seconds, maybe a little bit less because it's not as deep a joint, but you can be very generous with getting that light into the hyaline cartilage as best as possible. And of course, the goal is to make your knee joint as happy as possible. Yeah, it's pretty lame, but there you go. Okay, so what other things should you be using the laser probe for? Trigger points, tender points. We all know those. I'm not going to get into where they are. Palpate the knee. Wherever there's tenderness, treat. Now, if you just have the LDI 200, treat these points for a little bit shorter duration, maybe 5-10 seconds, 40 to 50% power. If you have the LDR, which is a red laser probe, maybe 10, 15, 20 seconds per point for analgesia or for pain relief there as well. Treatment plan. Patient presents with an acute flare-up of osteoarthritis, treat them 3, 4, 5 days in a row, if at all possible, then go every other day, so 2 or 3 times a week. Once they're 50% better or thereabouts, you can start going down to twice a week. And then once they're 80% better or thereabouts, you're about once a week, and then into maintenance. Maintenance will vary. I don't suggest doing once every 2 months or something. There's no point. Once a month or twice a month is, I think, good. You can also recommend them to purchase I'm not selling a stuff here, I'm just saying, if they purchase a personal therapy system, they can do some treatment at home, which is very beneficial. But they can come into you to monitor their progression, and you can do the laser probe as well. So, it's a good scenario, especially if the progressive disorders for patients. So I do recommend that. You may think, well, you're stealing away your business. First of all, you're trying to help your patient. Second of all, you help patients, they're going to refer patients to you. So there's lots of benefit to this. A lot of our clinicians do it. We also have a rental program. There's lots of different options there. So think about it as patients are still coming to you. You're going to direct their care still and still do the laser probe. And I think it will be beneficial overall. Chronic presentation for osteoarthritis. maybe 2 times a week, 3 times a week until it's under control. Then again, similarly, the maintenance program of 1 to 2 times per month or thereabouts is what I'd recommend. Big picture here. Review your joint anatomy. You know, every time I do these webinars, I learn something. I used to teach anatomy for 10 or 15 years. And every time I would prepare, I would learn something because you forget stuff, right? I mean, we've been at, you know, maybe some of us haven't been in school for a long, long time and we may kind of forget stuff, right? So it's always good to review and you'll learn things. So review your joint anatomy, know where you're treating. Treat the entire synovial membrane, as I mentioned earlier. Treat in the open pack position. You can also move the knee joint around a little bit when you're using the probe just to open and close the knee joint. That may also be helpful as well too. If you have the LDR, the red laser probe, then it's very beneficial for analgesia. It's a good investment. Again, here, yeah, you think I'm not trying to sell you anything. I'm just saying that having a red laser probe in your toolbox is a good thing. I use it all the time. I do recommend it, but of course, I know that sometimes spending a bit of money is tough, but it's a good investment. Okay, that's it for my webinar. Very quickly, before I get to the questions, we have a June 5th masterclass featuring a lot of amazing speakers, including Dr. Ashley Banjan, a neurologist from Durban, South Africa. He's spending 2 hours with you guys on June the 5th. Incredible, amazing results. Just for listening to him, it's worth the price of admission, which, by the way, is only $199 Canadian or $25 American, something like that. Very cost-effective for an entire 8-hour day of some amazing experts, including Ashley and Dr. Jan Tuner, who is one of the world's leading experts in photobiomodulation. He's now a retired dentist, not just in dentistry, but all aspects of photobiomodulation. He has over 27 papers. I looked them up this morning, peer-reviewed on PubMed. He's incredible. So he'll talk about TMJ and other aspects of photobiomodulation. Jan was very nice to join us on that day as well. And of course, we have Ben Ewan, we have a chiropractor from Halifax and a long-term Bioflex user, David Barker, massage therapist, Pierre Delorier, chiropractor from Vancouver, Lauren Brown, acupuncturist and TCM practitioner out of Vancouver, will give us an update on fertility. Muna, a chiropractor, talking a bit about the business side, very successful chiropractor using laser therapy. Dr. Michael Zitney in our own clinic, talking a bit about mindfulness. And this is stuff that was very important for treating chronic pain. Slava and myself, of course, we always like to get in there and talk as well too. Other upcoming events, we have advanced trainings, the cervical spine, and aging and cosmetic in September and December, I believe. So you can sign up for those for the early bird. And the freebie webinars are coming up on understanding the Bioflex personal therapy systems protocols, April 22nd, and the benefits of laser therapy and how to choose the right system in early May. And actually, I'm going to do one on hip osteoarthritis. I haven't put it up yet, but that will be in May as well, too.